Great. So, like I said, I'm just going to give you a tour of what I did last year. It was a really interesting year, actually, probably going to shape my career as a hematology registrar. And I thought ignite some discussion between the group, and I'd love to hear your insights. So, last year I took a year out of training and did a fellowship called the Darzi Fellowship, and essentially it's about looking at clinical leadership, trying to get clinical staff into management and leadership, and to apply theory straight to practice. So half of the time I was supposed to be at university and reading papers and the theory of clinical leadership and applying it to a certain topic. And the topic that I was allocated, I have to say I was allocated, I didn't choose it, and then I'm glad it chose me. At the time was sickle cell disease. I had an interest in hematology, and it felt like it fit the bill, but little did I know that I was being chosen for sickle cell. So the first few months, I was given strict orders to just go in and immerse myself in the sickle cell service and just try to understand take this time, almost the luxury of time and headspace to think about what is going on in the service and not try to react. One of the things that I feel like we're trained to do as clinicians is to try to fix the problem straight away. So a lot of the time I started going in, people were like, oh, we know you just have to fix as long as you fix the pain, the time to pain relief, that's it, that's done. And so the aim was to not get involved with anything and just try to see the service as it is and see it from all angles. One of the famous models that we were using at the time was the iceberg models, and it basically shows an iceberg, and the tip of the iceberg is what we see on the surface. And actually, these are just the symptoms of a huge underlying problem. And that's what I felt really fit in with sickle cell. There are a lot of people who are unhappy with the treatment that they're getting. We have so many reports coming out, the latest one being No One's Listening. And this is just a symptom of a huge underlying problem that is so integrated into the way things work within the NHS and outside the NHS as well. So I mentioned the No One's Listening report. You all know this was published in 2021, following the death of Evan Nathan Smith in 2019. But actually, it's not only about his death. It was about a few deaths, actually, that had led up to this report and multiple failures in care. And this showed, as you all know by now, that this was due to lots of different things: healthcare professional knowledge and awareness, negative attitudes underpinned by racism. It was due to unfair is the right word, unfair? To me, it feels like unfair distribution of investments and funding, and lack of community care and joined up care. And I think a lot of the patients on this call would probably agree with that in their experience. But actually, this is not new. In 2008, a very similar report was released, and that's 13 years different. And it's also looking at the poor outcomes in care. And I'm not trying to say that nothing's happened in that time. Correct me if I'm wrong, Ralph. This actually led to the rise of the HCC and organization around sickle cell. So lots has changed in that time, but it's a shame because when you read both reports, they are very similar in terms of their findings. And in Northwick Park, the hospital I was working in, we also had our own death. This wasn't included in the report because it happened after the report was published, and it was about the late Tyrone Airy, who passed away at Northwick Park, who is a sickle cell patient and deteriorated without the proper escalation. So I started off those first few months doing stakeholder interviews, trying to see, and like I said, it was an absolute luxury as a doctor to be able to speak to so many people I have probably worked alongside, but never had the chance to meet. That includes, lots of the management at Northwick Park. I don't think I would have ever got to know Ralph or Patrick in any other circumstance, bearing in mind that I have actually worked a job at Hammersmith and never met Patrick beforehand, or apart from through meetings. And of course, the biggest luxury was to actually meet the patients and the families. I had the luxury of time to get to know a lot of the patients, and I'd like to say that they are now my friends. So I have Hazel and Laurel here who have been part of our other endeavors, which we'll go on to next. But one of the things I did in my stakeholder interview at the beginning was to try to record the themes. And there was a few things that kept on popping up, and I tried to collate them based on how often they were said. So I used to take notes during them and then start to do a thematic analysis of what was coming up. And I started to be able to kind of see a theme and split it up into 5 main areas. It was a lack of an integrated service. There was a concern about patient safety. There was a need for collaboration. There are negative perceptions, and there's poor patient experience. And so from those 5 things, I was able to kind of start kind of drawing ideas of what would be the next best step. Like I said, those months meant that I could have thought about things a bit more deeply, and try to think about what would I do that would work below the surface of that iceberg model, rather than try to firefight and just put plasters onto big cracks. So in December of that year, I proposed that I was going to try to improve quality by establishing a collaborative sickle cell improvement network with direct and impactful community influence. And so it was trying to bring together the teams within my small network and pilot this idea that patients and clinical staff, alongside management and administrative staff, could work together to improve quality. Now, these were the theories I was using. I just thought I'd touch upon them if anyone's interested. It's about using a strength-based approach and co-production. So strength-based approach is talking about looking at people as assets, and instead of thinking of them as doing things for them, actually we can do things together and doing things with them. And these were the theories I was using and actually wrote up on. I hope to one day actually publish it, but I haven't got there yet. And this led to the birth of the London Northwest Sickle Cell Patient Group. And I was really lucky, because one of the things about the strength-based approach is to look at what's strong and not what's wrong. And in my community of London Northwest, I really felt that the patients were what was strong. And I was right, because I had reached out to patients. I had about 40 patients I managed to get hold of, and a turnout of 17 regularly into my groups. And I was really lucky with that. I don't think I could have imagined such a great patient engagement. And I really do think that's one of the assets of the sickle cell condition, is the community that you can build. We had about 6 meetings, but I managed to only fit 5 of my minutes from January all the way till the end, which was July. And in those meetings, we started talking about patient experience, talking about the idea of collaboration and quality. Then we started brainstorming, thinking about what could we do together, and how we could work on those things. And lots of things came out of it. And this actually makes me, just looking back at it, and not everything was definitely like followed through, but the fact that we were able to uncover so many issues, and I hope kind of caused ripples in the system. I really do hope that there are some changes. One of those things I can see here is the sickle cell retinopathy. Again, pulling the people from the group, we were able to kind of connect them with Miss Dina in London Northwest, and only recently in the summer they had a Westfield event. I'm not going to claim any of that success, but I'd like to think that I was a cog in the wheel to connecting these 2 dots together. And also looking at other things like employment and education, and trying to piece together what could be improved in that aspect. But actually, I'm going to talk about the things that I did follow through on, and those were, I think I've got 2 or 3 things. So the first thing was quality. That was my main interest. And sorry, Ralph, tell me if I'm talking too much at all. But one of the things I was really interested in was quality. And quality is something that is subjective and objective. So how we measure it in the clinical setting is based on numbers or based on results. Now, these are the quality measures of sickle cell. And this is what I presented to my first group meeting, and Laurel was there. And these are how the NHS and the National Hemoglobinopathy Register measure quality. So if you get analgesia within the first 30 minutes, if you've had an annual review, and if you are on treatment, or whether you're on treatment or not, and the NHR look at whether you've had significant complications. So if you're a patient who's come into A&E, has had some sort of analgesia, bear in mind this could be paracetamol, within 30 minutes, and this can also be given in the ambulance setting. If you have had an annual review at some point and are on, or maybe not on treatment, depending on that, and have not had any sort of significant complication, according to the NHS, we are doing a good job. Okay. And that's not good enough, because this does not reflect the findings in the report. And I thought, let's look at a similar condition. Let's look at what happens in cystic fibrosis. A cystic fibrosis is a condition that affects is more European population, but similarly, it's passed down in a similar way. It's an autosomal recessive. It is picked up on newborn screening. And actually, sickle cell in the last few years has exceeded in terms of its prevalence in the UK. So cystic fibrosis, these are their metrics. They're looking at when you were admitted, did you get admitted to a specialist unit? Were you given a side room? And the reason that they need a side room is the risk of infection, which we know is also present in sickle cell disease. Did they get access to physiotherapy that year? Did they get access to a dietitian that year? And did they get access to a psychologist that year? Finally, what's their weight? And according to the Cystic Fibrosis Trust, they also take measurements on education and employment. And this really hit me hard, because as long as you're, there's this famous quote, I want to get it right the first time, but not everything you count matters, and not everything that matters counts. And this really was clear from how we measure quality. And I, these sorts of things put it into perspective for me, but also I think to the patient group. And so we thought, okay, we might not be able to change NHS England today, but why don't we make some changes locally and see what we can do? And so we thought, we'll put together an inpatient questionnaire. Like I said, start small and pilot things and see if we can put this sort of metric into our service. And we, as a group, put together 10 questions that we wanted to measure in a questionnaire. Now, bear in mind, one of the things that people talk about a lot is the pain, access to pain, and these were the questions, right? So the first one was about pain. Now the next 9, I'll ignore the last 2. So the next 7 were not about pain, and these are things that are important to patients. I did not write these questions. It was about knowledge of the staff, whether things were explained to them, whether they were involved in the decision making, whether the ward had the correct facilities for them, they had access to psychological services, access to coping at home, and access to kind of information to share with their school, college, or workplace. And so that really highlights what you need to get right in order to get good quality of care. It's not just all about getting that pain relief within 30 minutes. There's a whole host of things that happens afterwards and beforehand in sickle cell disease. So we moved on from that and said, okay, let's put our knowledge collectively whilst we collect data on the questionnaire. Why don't we work together on I've got a year here. At the time, it was a few months left. Why don't we do something collectively? And we thought we would tackle healthcare professional knowledge and awareness and pull together a sickle cell simulation program. Now, simulation is something that doctors and actually a lot of different professionals use, is where they recreate scenarios in a fake environment. And it's really to make your mistakes and practice something. And we thought we would introduce sickle cell scenarios in our department, but do something differently and actually involve the patients. So this is Christina. She's one of the patients from the group. And she decided to come in and help us do this. So we did this a few times. We would run a scenario where we had someone who was in pain and how we would manage that. Bear in mind that the doctors in this room all said that they had never met a patient who had sickle cell who wasn't in crisis. So this is the first time they've seen a patient with sickle cell who looks well. These are all A&E and general medical doctors. So they have no other reason to see a patient with sickle cell like who would be well, because why would they come to A&E? So it's just a really insightful thing that I thought came out of that. And I have to say, even myself, I hadn't seen patients who had sickle cell who were well until I did my hematology job and started seeing them in clinic. The second thing we did was, within this program, we decided to include Tyrone Airy's story. We felt that we couldn't do this without talking about the reason that we all came together, and that was through Tyrone Airy's story. We created 3 scenarios. One was about Tyrone Airy, one was about a chest crisis, and then one was about a really complicated case, a true case that happened in Northwick Park, and that was more aimed towards senior doctors. For the simulation program, we got Tyrone Airy's mother, Lorraine, to come in and get an interview from her that would be shared with every simulation training on sickle cell. So what we did was we created a video and we spoke about Tyrone Airy for this to be shared with anybody who does the simulation training, but also anybody who ever wants to watch it. I wondered, Ralph, thumbs up if I have some time just to show Lorraine's part. Yep. I don't know what I've just clicked. Here we go. I'm just going to I think I've shared my audio, and I'm going to fast forward to Lorraine's part, just because I think Tyrone is really important in my journey as well. One of these cases is about Tyrone Airy. Can you hear? Yeah, okay.
Yeah, so Tyrone, very handsome young man, handsome, beautiful boy, so handsome on the outside and beautiful on the inside. He was always quite happy, liked to joke around, liked to have a laugh, absolutely loved music. I remember him being like 2-3 years old, and you couldn't keep him away from a turntable. He had a very eclectic mix. He liked a lot of the stuff that I liked. So he had a bit of like an old head on him in a way, very wise, very, very intelligent, and very emotionally connected. So he didn't do like a lot of sport or anything like that, but he loved to dance. He was just very, very, very good company, good at listening, very philosophical, very, very, very creative as well, extremely creative. Even being young, I remember him experimenting with clothes and things like that. He always had his own style. I used to make costume jewellery, and he actually asked me if he could learn. Which I was really inspired by, because with sickle cell, it was always a problem for him to be able to work. He'd find work, and then, once he'd had a crisis, then, he wasn't able to necessarily keep jobs. But he always got them though, so I think the charismatic smile just meant that he did always get jobs. But his passion was on the creative side. He loved to listen to music, he loved to play music, so I thought maybe he might be something like a radio presenter. Before he died, bless him, he was a singer, songwriter, sort of neo-soul type singing. He went by the name of Time Alone. He kind of found his forte, something that he could do on his own terms. So I found out he had sickle cell when he was about 3 or 4, something like that. Didn't know anything about it. We used to go to a children's hospital whenever he had a crisis, but it was awful because, even being so young and one minute being okay and then the next minute, it's just like night and day sometimes, the way the pain would just come on. And it was quite traumatic, the sickle cell, because we go to hospital as a child, 6-8 doctors holding him down, to put the cannula in and things like that, the injections, the blood tests, so I think it was quite traumatic for him. When he was younger, sometimes he could be hospitalised 3-4 times a year, which was just, really quite debilitating. I remember him being about 8-10 years old, And that was the first time that I heard the hospital say that he only comes in because he's addicted to morphine and then don't want to give him pain relief. So that was really quite soul destroying, because if he's in pain as a child, and he can't get pain relief, what do you do? And then as he got older, going to hospital just became torture on top of torture. So he'd be in pain, he wouldn't want to go to hospital. The pain is too much, you couldn't. There's no way you could keep him at home or anything like that. I used to feel like he could, literally break my arm when he's holding on to me, because he can't cope with the pain. And then that when you go to, when you get to the hospital, he's going to be told, that he's not really in pain. He's got to wait, he's got to have paracetamol or something like that. He's addicted to morphine, there's no swelling, or his hemoglobin might be low. Other times his blood count might be normal. That denial of his pain constantly, relentlessly, was just, very, very, very traumatic. I don't think there's one time that he came to hospital and wasn't told, sit still, put your hands in your lap or whatever, and if you don't behave, then we're not going to deal with you, and those kind of things. So this is where it just became like absolute torture on top of torture. It used to rip my heart out that the only place he can go, he can't go anywhere else. And me as a parent, there's nothing I could do. But going to the hospital would always fill him with dread. I don't think there's been a time that he's gone to hospital and he hasn't been filled with dread, just because he doesn't know, what kind of reception he's going to get. As a parent, once he became like over 18, and he himself didn't always want to worry me with his crises, so most of the time he wouldn't necessarily let me know. There was a time when he came to hospital, he was actually worried about the crisis that he was having. So at one point he did sickle in his lungs, and that pain, he did contact me and say, what can I let them do or not let them do? It turned out then that he had pneumonia, and they had to put him in an induced coma for about 5 days. So he let me know then. So this time I didn't know that he had come in. He was traveling as well. He was living in Egypt for a while. So he was back from Egypt, and I didn't know he was in hospital. I only found out when he passed away. And because it was such a short time, he only came in, he came in the night, and he was gone by the morning. He would have, normally kind of waited to see how it went, and then let me know. So on this occasion, it's like we never got to that stage. When it came to him saying that he felt like a caged animal and he needs pain relief, he didn't need to die when he did. So if he had received the care that he should have had, he'd probably still be here with us today. So that's the saddest thing for me.
Yep. So that's the video part of the video that we put all together. And actually that's probably the most powerful part. It was talking about Tyrone, and putting the simulation scenario into context. It's the great thing about simulation is you get to try on something fake, you can make your mistakes, you can have feedback, but sometimes it feels strange because it's a doll, and it doesn't feel real. But actually when we do the Tyrone Airy case, it's important to recognize that not only is Tyrone's story real, but all the cases that we were doing are based on true presentations of patients with sickle cell. So I just thought I'd wrap up. Sorry, I don't know how long I was supposed to have, but I hope I was within. So number one is I found that from my year that collaboration, especially with something as complicated in terms of the issues faced, not the condition itself, but the issues faced by those with sickle cell disease. Its collaboration is absolutely necessary. We cannot talk about, decide what's important to them without them. And so I used to use this at the slogan for every one of my meetings: nothing about us without us. It's actually one for when they were doing disability rights, but I thought it was really important because as long as we decide what's important to you, we're going to continue to put things that aren't, like the ones that I've shown you, the NHS England metrics. I would like to think that this year I tried something new. I tried something outside of my comfort zone, and it might not have got the same level of success if I had been there for a few more years, for example. But I'm happy that I did try rather than not, and trying to stick to the kind of sharp end of the iceberg. I really did connect with this idea of asset-based approach and reciprocal partnership, which are two things that I take away now, which is this strength-based approach and co-production. The outcomes, like I said, were unpredictable, and that I had to be as flexible as I could and as inclusive as I could, and be really wary of that. And one thing that I think that still kind of hurts me a little bit is that sustainability is, we all have these great ideas, and we all want to improve things within the system, but sometimes sustainability is generally overlooked. And I had a wonderful year and I've learned so much, but I'm not there anymore because I had to go back into training. And, I'm not sure whether all these things are going to be continuing the same way that they had started. And I really do hope that is still happening. Before I end, that's my name and email address. One of the other things that came out of this year, which I am also equally proud of, but not the topic of today, but I thought I'd do a little shout out, is the Sickle Cell Education Series. Me and my colleague Rosby, also there in Scrubs, who works at the day centre in London Northwest, thought we'd put together an education series. It was actually aimed at patients to kind of build understanding about their condition and knowledge to give them the power to, communicate with doctors and express how they're feeling when it comes to their condition, and their knowledge to do so. But actually managed to include loads of healthcare professionals in that, which is great because we know that there is a huge void in healthcare professional awareness and knowledge. We have so far hosted 5 episodes. We have had different hematology consultants come on, and also a nutritionist. I don't know if any of you know her, but Claudine Matthews, who came on our last series. And we've also had Hazel and Laurel feature on them. If you ever catch an episode, you will definitely spot them on there. So thank you very much. I'd like to have a discussion if the time allows. I will stop now.
Thank you, Layan. Does anyone have any immediate questions for Layan?
Not questions, but I would just like to say working with Layan for the year was absolutely amazing. And I know that there's a lot of groups out there and people out there that are really trying to help. But you were really special. I have to say, you were really special. And I know that like I said, I know that there's a lot of people, even you, Ralph, yeah, that are special. But, when you meet somebody who genuinely, and I think that's what I have to say, when you're genuine about what you're doing, that's all I'll leave it and say, because I think the video kind of like really was touching and really made that everything that you do and other people who do that really want to help, it makes it real. It makes it real, the reason why the fight has to just keep continuing and awareness just has to keep being raised, regardless of what, regardless of what we go through, we have to continue doing things to help what Layan's done, what Ralph is doing, and what many of the other people out there are doing to try to help. We're not always going to get it right, but what we do get right is good. So the things that you have done, like the simulation and the other things that you've done, have been amazing, and your group still continues.
I'm so happy to hear that. So happy to hear that. Thank you.
One thing I was going to ask Leanne is, can I, you possibly have sent this to me previously, but would you be able to send me the minutes of the London Northwest patient group?
Of course.
The kind of colourful ones. And also, how did you do that as well?
I thought I'd do visual minutes, and I got the idea from Laurel because we had a listening event at the beginning of the year, and I don't know, I didn't even realize that we should document this event, but Laurel was scribbling away and created this lovely post. I don't know if you've seen it, Ralph. If not, I'll send it to you as well, of all these different quotes from different people, and it was just so lovely to look at because I felt like you don't have to actually read the minutes. And so I thought I'd do the same. I did it on Canva. There is a trust, the ED department had an account, so I started using their account. But and then the Sickle Cell Education Series also bought one, so started using that. But if Imperial Trust has one, I really love Canva. Yeah.
Okay, useful. And one of the things that was notable about that immediately kind of got my mind thinking a bit is that while we've uploaded some information and bits and pieces on the website for patients around CAD patient leaflets and information about different things, one thing we haven't really done is kind of develop specific information leaflets for workplaces and schools and things like that. Now, with schools and colleges, it's a bit different because, of course, you've got the Simon Dyson resources that you can try and direct people to, and we've tried to do that when we've done sessions with the school nurses and teachers. But yeah, I think trying to do something specifically for workplaces might be a good idea. And so a kind of general education session, but B, also starting to maybe think about creating some resources for it as well.
So actually, this was one towards the end of my year was one of the things we were going to do. And I'm actually going, so I actually got in touch with Simon Dyson's actually retired now, but his team, I got in touch with them to see if we could work together on trying to update those current things available. I think they're currently no scope because they're very evidence-based kind of guidelines. So I don't think they'd be looking into working with us at the time. So we, again, as a group, thought, let's just do it ourselves. I don't know I have some of it, and I'm really happy for anyone to kind of take this and run with it if they are looking to it. I know I've kind of given it back to the London Northwest team. Laurel, do you want to tell me where it is now?
Yeah, we're still working on it. We're still with it. We're now getting like case studies. So
fantastic.
Yeah. So
are you happy for me to share just on the screen with it?
Well, what's gone in so far? Because I think we're updating it because I have to share my ill health retirement.
Yes.
So we're filling in sort of like people's case studies, what they've gone through onto it. But we're still working with it. I think Annika was supposed to contact you to find out.
I'm just going to share the document.
Yeah.
Windows. Are you able to see it now? It says Sickle Cell Employment Toolkit. So this is what we were working on before I left, and then I kind of handed it to the team. But it was looking about how we can create I think we reached a point with the group where I realized, actually, I can't wait for things to change. Let's see what we can do in our own capacity as a, really motivated group. And so we started writing things like that and linking different parts of the document to different websites that are, rather than reinventing the wheel, just flagging different things to different patients. So where to get your risk assessment done, how to look at different reasonable adjustments already done by De Montfort University. And then we wanted to include patient stories in between. I haven't actually opened this document since, but we also created our own Sickle Cell Employer Toolkit, something that you could print out and then go through. It's a work in progress, but I think if you have any ideas, Ralph, at any kind of further connections, I'm sure the group, that's Laurel over here. Laurel, I got that picture from Google for you. yeah, so we were doing things like that at the time, which I
No,
think
that
is
sounds excellent.
it's definitely needed, especially with children in school. I steered well clear from children last year. I decided I can't take on that much work, so I was strictly adults, but I could imagine that
For
children.
the community program, in North West London, there's going to be a clinical fellow attached to it, and I do wonder if we could maybe get that person kind of involved to a greater extent with this sort of project. Though, to be honest, at the moment, any time there's anything new comes up, people are already giving that person a giant workload.
It
But
is, yeah.
yeah, I think that's definitely something we could have a look at. And as a HCC, hopefully once I've managed to get a project manager in to help out, I can maybe start getting involved a little bit more in this kind of stuff as well.
Yeah, well, there's definitely Laurel and Annika are good contacts if you need to get through the team, and I'm always there if anybody needs anything else. Although
Perfect.